Welcome, everyone. We are so glad you are here for the July monthly webinar for the Arkansas Behavioral Health Integration Network. We're so glad you're joining us. Please, put your name and organization in the chat. I want to remind everyone we are recording today's webinar, and we will be posting this on the ABID website along with the slides. So know that you are being recorded, staying on today's call. And with that, I'm going to ask Dr. Gibson to introduce today's speaker.
Yeah, thanks, Kim, and thanks everybody for being here. We know that our participants are as important as our speakers, and that we are happy to get this information, but also to continue dialogue around how we can all do better in what we're doing, and especially focused on integrated behavioral health. And as you might have heard as we were chatting, I met Dr. Scott Breidinger at the Mayo Clinic Integrated Behavioral Health Conference in Phoenix that was in January. And I was so impressed with his presentation that I, immediately went up to him and said, "Hey, can you come to Arkansas?" And so we've been in conversation since January, trying to find a good spot for him to be able to bring this message to us around digital solutions for integrated behavioral health. Dr. Breidinger is a board-certified psychiatrist in the Division of Integrated Behavioral Health at the Mayo Clinic. His work is focused on the management of psychiatric illness in the primary care setting through team-based care models. This clinical work serves as a foundation for problem identification, hypothesis generation, and solution iteration with his implementation and design work in healthcare. He builds services and products that make mental health care more efficient and accessible, often through better technology integration and improved alignment of stakeholder initiatives. In his teaching roles, he works with medical students and postgraduate medical trainees, including residents and fellows, and provides continuing medical education to clinicians in the delivery of psychiatric services in the primary care setting, innovation in care delivery, and psychotherapy practice, amongst other topics. The thing that many of you may know or may not know is that the Mayo Clinic has been one of the leaders in integrated behavioral health. And one of the things that they're excellent in is providing evidence-based care and continuing to bring evidence to us so that those of us who are out in the field can know that what we're doing has an evidence base behind it. This is, I think, really critical for us to get the outcomes that we want to get as we're expanding the way healthcare is delivered. And it's so, everyone is hearing about digital health. There's so many options out there, apps, etc. And one of the things when I heard Scott presenting is that I really was kind of settling in and into the conference and thought, well, this is going to be one of those conferences where I'm going to see a list of apps and then I'll get on them, and it might be something that'll be a little bit, useful. But actually, I was very intrigued about the way Scott was helping me to really think about, well, yeah, what is the role for digital health, and how can this become really mainstream and really effective? So it was the challenges that he brought to me in terms of, how does this really work in? And since then, there's been so many presentations. Everyone's talking about AI and what's the role, and how does this really fit in with behavioral health care? So I'm really happy for you to bring this to us, Dr. Scott Breidinger, who I didn't say is assistant professor of psychiatry at Mayo Clinic. So thanks so much, and I will turn it over to you now.
Well, thank you so much, Dr. Gibson. It's really a pleasure to be with the group here today. And I appreciate the introduction that covered a very wonderful orientation to what I hope to convey. So I'm going to jump ahead a few slides. Thank you for, as soon as I figure out, there we go. Okay. So I don't have any financial disclosures, just the perfunctory slides to start with. Regarding the learning objectives, I'm sort of going to break down the conversation, I hope, into three main components, talking a little bit more about the idea of how we conceptualize a problem and how it relates to effective problem solving. And from there, sort of pivot to talk a little bit about the vocabulary that I think is really important, and the dimensions to digital design that make any given tool or solution effective and useful to patients and providers. And then with some time left over, pivoting a little bit again to talk a little bit further about emerging trends and opportunities to utilize digital solutions when we think about the problems that we're facing in providing mental health care in the primary care setting. So from there, I'll start here. As Dr. Gibson said, when I have taken a look at various publications and been an audience member in various talks about digital health, oftentimes I'm given a list of apps or companies that are doing interesting things in particular spaces. And certainly when I was conceptualizing this talk, that could be one way to go to give you all a sense of who the leaders are in addiction and CBT and mindfulness therapies. But I think it's a missed opportunity because this is a very dynamic and difficult to navigate marketplace. It's always changing. This is a screenshot that I pulled off of the internet. And a lot of the companies here have changed fundamentally just within the past couple of years since this was taken. There have been mergers and acquisitions. Some have gone out of business. Some, in fact, as I'll mention, are under FTC investigation for some less than appropriate actions in the healthcare space. So my hope is that by providing a little bit more of a conceptual framework for how we think about the role of digital technology and particular solutions in the implementation of care, it might go a further way if we all have a conceptual framework that we can then map onto our own challenges with our own healthcare work, and give us a little bit more of a map for problem solving to our specific system. So as a talk on technology in the 21st century, I'm going to start in the only logical place to do that, which is 24 centuries ago in ancient Greece. And I say that tongue in cheek, of course, but I think there are two ideas that I want to start out with that I hope will provide a little bit of a foundation to help us understand where we are today and where we need to go. And in some organizational domains, there's this idea that gets discussed a lot of first principles thinking. Some less so, and I think in healthcare, it's perhaps an underutilized concept. But first principles thinking is really the idea that when we're faced with complex problems and challenges, the most fundamental step that we need to take in order to have any possibility of a useful solution is to really break down that problem in its subcomponent parts and understand the subproblems at their most elemental, fundamental level. And I think that tends to be underutilized as an operational approach, an organizing philosophy when we look at healthcare challenges, with a patient, within a healthcare clinic, or within a larger system. And in particular, I think it's a problem with digital technology that too many people see in our field, broadly speaking, see apps, quote unquote, or patient monitoring as novel solutions that are going to fix numerous and diverse problems. But I don't think that that's the case. And to add a little bit extra emphasis, I have an illustration of a device here that I think is a great example of some of the pitfalls of seeing technology as a way of solving problems without rigorous thinking. So this device, some of you may have seen it before or familiar with what it is. It's referred to as an allophile, and supposedly it was first described by Archimedes in about 400 BC. And what it is a contraption that basically in that large drum contains water. And as you can see, there's an illustration of fire underneath that. So when the water is boiled, it turns into steam, it goes up the valves and into that cylinder, or sorry, excuse me, the sphere rather. And the steam in the sphere has its only outlet is through those two directed valves. So functionally, what this is a steam engine. And this was used throughout the ancient world as a novel form of technology for absolutely nothing. And it actually is the case that civilization took another 2 millennia to figure out how to actually engage the technology of steam power and put it to productive use for various pumps, and then ultimately really took off with locomotives. And I think that, to me, this is a really important organizing idea, that technology in and of itself is not going to solve problems. It really has to be contextualized appropriately in order to be used effectively. And I think the same principle really carries through in healthcare and mental health care specifically. So I hope that might be a useful starting place. With that being said, I'm going to pivot slightly to talk about some of the challenges that we're seeing in mental health care today. And I'm pointing to 2 headlines that were focused on a company called Cerebral, just for added emphasis. I, of course, don't have any relationship, positive or negative, to this company, but Cerebral, I think, started out with very genuine motivations to expand access to care for individuals with mental health concerns. And they used a telemedicine service, their own proprietary telemedicine service, to expand access. But over time, what wound up happening is that they sort of became a notorious supplier for easy stimulant prescriptions, and really sort of lost track of what their initial mission was. And in my opinion, I think they started out, as I said, with very genuine motivations, but didn't understand the problem that they were trying to solve fully, and sort of were led astray into some precarious territory. And I think it's a useful case example to dig in a little bit further and understand how they went astray, so that we don't fall into the same pitfalls in our own work. And to me, the most useful starting point, I'm going to pull from a professor at Harvard Business School. Unfortunately, he passed away a few years ago, but Clay Christensen has written about innovation in many different domains, and he's written about innovation in healthcare particularly. And I think his conceptualization of different, what in this slide are referred to as business models, I would say we can use that term interchangeably with operational models when we think about implementing healthcare in a nonprofit setting, for example. But the 3 distinct business models are what he calls, first, a solution shop, which is basically the application of expertise to understanding, diagnosing, and proposing a solution plan for complex problems. So any form of diagnostic medicine is a really great example of that. The second business model is what he calls a value-added process. And this is basically, I think of it in a more linear term, that you start out with a raw material, and you have some sort of algorithm or process to enhance that raw material and turn it into a more useful or more valuable product on the other end. Some examples of that would be, quintessential any manufacturing process, building a car. In healthcare, I think something like a joint replacement surgery would be a good example of that. And within mental health care, I think you could consider a course of ECT to be following the same type of operational model. The third one, the facilitated network, we'll focus a little bit less on, but just to be aware of and to round out the discussion, a facilitated network is really any sort of infrastructure that makes it easier for individual A to connect with individual B when they have a shared interest. So that may be a dating app, it may be Craigslist in mental health care. I think the Psychology Today website is a pretty well-known example of a platform that makes it easier for patients to find a provider. But focusing in on the first two business models, these are very distinct steps with their own distinct processes when we think about patient care. And diagnostic clarification, assessment, and treatment planning is absolutely a necessary first step to put in place the right treatment algorithm and standardized evidence-based treatment process. And I think if we look back at a company like Cerebral, they neglected to understand, in my opinion, the first half of this process. And they sort of bypassed it, presuming that a patient can figure out what their right diagnosis is and figure out what the right treatment should be, and then engage with the company that will provide them with the right treatment. But in my opinion, it's as simple as recognizing that the wrong diagnosis plus the right treatment is in fact the wrong treatment. And I think that this was an example of a company not fully using that first principles thinking to understand the nature of the problem that they're attempting to solve. And it really led them astray. And again, I think it's important to come back to the fact that, as with, I think, most organizations in healthcare, I think they had genuine intentions. But it's important to be aware and understand some of the pitfalls of oversimplification. I'm going to build upon this model a little bit as we go along and add as an underlying layer that I think is pertinent to both of these operational components, digitally enabled patient monitoring. And that's been in discussion for a number of years. This article that I'm referencing in this slide was published in the New England Journal in 2012. It really just talks about the idea that to be effective with healthcare provision, we have a huge opportunity to monitor patients, to leverage digital technology for what the authors refer to as the 5,000 hours that a patient has outside of the clinic in a given year. I would politely suggest modifying those numbers, because what they're referring to here are actually waking hours. But we now know that there are digital tools that we can use to monitor sleep quality and quantity with some degree of good validity. And as we all know, sleep is a very important component of overall well-being. So the potential for enhancing our monitoring of patients is quite ubiquitous. From there, I think it's also important to see as an additional layer of the operating model of patient care to look at the digital tools, the infrastructure of our EHRs, right? So how do we record data, clinical data and otherwise? How do we communicate with patients through telemedicine, through video, telephonics, or asynchronous communication through text? All of these are core components of the infrastructure, the digital infrastructure that we use for patient care today. And then thirdly, I think another layer that's distinct from each of these is the domain of data-driven insight. So I like to sort of think about this as the term that I use in many of my discussions are thinking about the numerous streams of data as going from a byproduct of care, right? There's all this diverse stream of data that gets produced in patient care that evaporates pretty much as soon as it exists. And really thinking about the opportunity to capture all of those different data streams and treating it as a core enterprise asset as opposed to a byproduct of care. And I think we're really on the cusp of this being profoundly different in the future because of AI opportunities and some of the work that companies are doing in this space to capture diverse unstructured data streams. And then finally, using specific digital therapeutics. And digital therapeutics have a specific terminology that I also I thought this would be a good time to turn and reinforce some definitions in the digital healthcare space. Digital therapeutics are specific products that have been researched and assessed and have a demonstrated evidence base for preventing or treating disease. And the FDA has a role in vetting digital therapeutics and an approval process for that. So there's a pretty rigorous regulatory oversight component to digital therapeutics. Now, thinking a little bit more broadly, digital medicine or medical device is a little bit less constrained in its definition. And the idea here is that a digital device, digital medicine, describes any evidence-based software or hardware that can be used to measure human health or deliver evidence-based health content. And the regulatory oversight varies in this domain. And then the most broad encompassing term, which I would say it would be digital health or digital solutions, really is any type of tool that engages with health-related content through a digital user interface or health data collection. And this does not necessarily require any regulatory oversight. So just wanted to provide that context and clarification and conceptualize the role of digital therapeutics in particular as it relates to standard evidence-based treatment processes in our care. I hope now that we've sort of gone through this map and we've built out an understanding of the different components of our operational model, it's becoming more evident that when we think about digital solutions, we really have to conceptualize what is the specific problem that we're attempting to solve, and where does it fit into that architecture, that framework. And this slide is just an example of the numerous different digital tools, different technologies that may have a role at different points in that framework of providing care. And the question of what to use and when to use it really comes down to precisely and accurately formulating what the problem is that you're trying to solve. So I think, overly generalized solutions saying for this type of patient, use this therapeutic or this tool doesn't really go very far. And we have to understand the specifics of the healthcare system, the context that we're attempting to implement a tool within. I wanted to pivot from there to talk a little, to apply a population health lens to the problems that we're talking about today. So if we conceptualize 1,000 Americans with a diagnosable mental illness, I think it's useful to understand how they get care and who provides the care. So of that 1,000, about 12% are going to be seen by a psychiatrist. About 20% in total will be seen by any type of mental health care specialist, which leaves about 44% that will see any healthcare provider, meaning, in turn, about 26% of this group is going to be seen only by a primary care provider. And of course, as I'm sure many of you know and can surmise, that leaves about more than half, about 56%, that aren't going to be engaged with treatment for their mental health challenges. So if we're looking at this problem, this issue from a population health standpoint, I think you can see that the types of solutions that we're looking at and that we're interested in are going to be very different depending on what group we're speaking with, what group we're engaged with, and what group we want to help. So for the 56%, I would probably be most interested in thinking about innovation in access and navigation to care. When I look at that 24% that are seen by a primary care provider, my interest in what types of innovation are going to change. I'm interested in enhancing diagnostic sensitivity so that we can capture more patients effectively, provide referral pathways to specialized services and programs, and maybe also think about more universal behavioral wellness interventions that might apply to this patient population to prevent them from needing more specialized, more acute mental health care. And then with the 20% that are being seen by a mental health specialist, the minority in this group, the question for me becomes, how do we deliver care more efficiently and make use of the psychiatric expertise that we have and spread it more broadly and scale it up? And the solutions and the types of innovations I'd be interested in bringing to that patient population look different, in my opinion, from the other two. So I hope that begins to give you a sense of how we need to think about problem definition and really from a first principles thinking standpoint, break it down into the most elemental parts before we can effectively even begin to think about what are the innovations that we want to bring to the table and try to help and support this modality of care. From here, I think it's useful for us to look a little bit more precisely at the key properties that make a digital solution useful to patients and providers. And I think this is also an underappreciated aspect of the conversation. And the reason for that is that, again, it's a place where our tendency in healthcare is to bypass some of the operational realities and just think that if we have an app and we tell a patient to use it, it's going to be an effective tool. The reality is that this trend that is mapped in this slide is very ubiquitous. And what it shows is usage of different types of healthcare and mental health digital applications. And the drop-off rate is ubiquitous, right? And you might be able to think back on your own experience. If you're anything like me, I have probably dozens and dozens of apps on my phone, but there are only about 5 that I use on a regular basis. And so what it shows is that the effectiveness of an app has a lot to do with the specificity of the design and the problem it's attempting to solve. To look at this from a slightly different direction and triangulate how we begin to address this problem, there's another paper that was published in JAMA a few years ago. And the authors of this came up with what they referred to as a novel stickiness metric. And what they did, sort of similar to the prior study that I just showed from a journal called JMIR, they looked at the number of monthly active users over the number of total downloads of a given application. And I'll save you some of the details, but to me, the major takeaway from this study was that the more specific the use case, the higher the stickiness. So the more sort of abstract and general and conceptual the application was, the less pertinent patients felt it was. And so you really need a digital tool that's tailored to specific needs for it to have any hope of being sticky and therefore useful to specific patients. There's another review that was published in JMIR, which I think does an excellent job of giving us a conceptual framework for understanding the design components of an app or a digital tool that is likely to be used successfully by patients and providers. And these are the different elements. I'm going to go through it really quickly, but I think these are important to understand both from a few different levels. That of being a provider, making recommendations for maybe some specific digital tools for your patients and having to review and maybe vet them yourself to some degree, as well as health service designers and implementors. And then in addition to that, maybe we also may have some digital innovators and designers in the audience today, and thinking about these different dimensions to app design and digital design can be very helpful for making sure that the solutions that we're building ourselves really speak to the needs of the patient and the needs of the provider that we serve. So user interface aesthetics, I think, is the first thing that's really underappreciated. And I believe that there's a very profound distinction between research grade apps and commercial grade apps. And of course, there's a big difference in the amount of capital that goes into producing these. But one of the challenges from a research and evidence-based standpoint in our field is that oftentimes the products that get studied, I think, are research grade. And part of the mechanism of action probably has a lot to do with the user experience, the user interface, and the quality of that may pull patients into using a particular tool. And we don't really have the granularity of detail in the way that the research is conducted today and measured today to really recognize this distinction or think about aesthetics from a measurable standpoint. But it's a non-trivial part of determining what makes a digital solution useful and one to be used by patients and providers alike. Navigation is the next core domain of digital design. Ease of use and automation are the subcomponents that constitute navigation. And these are really essential to making a useful tool as well. Next, talking a little bit about personalization. This is one of the things that I was particularly interested in myself as a designer, a tool developer. I think that when we think about behavioral activation for our patients, one of the challenges is making the goals specific to the patient, trackable, measurable, what we refer to as SMART goals. But if there's a process to building that into any digital tool that might support behavioral activation. And these are the elements that make that personalization possible: assessment, feedback, and ability for the patient to manipulate and modify their own goals and sort of self-tailor them as well. And then reinforcement, a little bit before it turned 8 o'clock, with the group that came on, I was talking a little bit about collaborative care and the use of contingency management, which is basically a token economy for supporting engagement with care that's often used in the addiction setting. And there's a huge opportunity, in my opinion, to translate this into a digitally native platform and really enhance the digital care that we provide. But this constitutes specific rewards that could be tangible or intangible, and reminders that might help the patient engage with helpful activities, and perhaps reminders to avoid certain activity as well that may be unhelpful to their wellness journey. Communication is the next dimension that was reviewed in this article, and some key takeaway points. And I should pause here and say that, of course, not every digital design needs to have all of these components checked off, but these are some principles of design that are really useful to think about when we think about what we want to build and why we want to build it. So with that being said, something that was really useful to patients was the ability to have peer-to-peer communication and direct access to professionals. So again, depending on what it is that what the problem is that you're attempting to solve, either or both of these elements could be instrumental to building and maintaining a useful tool. And then the type of the quality of the message presentation. Is the language simple, non-technical? Are there direct instructions for action? The tone of voice, is it friendly, non-judgmental? All these things that we know as care providers that go into our in-person communication. The question is, how do we translate that effectively in the digital sphere? And then finally, of course, presentation design. Can we use visuals and multimedia to enhance text so it actually feels like a humanistic means of communication? And then the final dimension was credibility. And this is a really important one to think about. How do we convey trustworthiness? Some of the specific elements that were touched on in this article are that ad-free apps were perceived to be much more credible than ones that had a sort of financial mechanism of sustainability through selling ads. And having a specific explicit emphasis on evidence-based recommendations is also something that tends to be highly valued by patients. And then in parallel to that, thinking about demonstrating that confidentiality is thought about, that there's a specific policy in place, and that data is appropriately anonymized in its collection and maintenance is very important to patients as well. So I hope that that overview helps us in our individual examination of digital tools, thinking about these specific dimensions and how they might fit into our understanding of whether a specific tool is going to be useful as we're problem solving in our own respective healthcare systems. I wanted to turn from there to think a little bit more about some emerging trends in the field and opportunities to use technology for mental health care innovation. And I thought I'd start by giving my 2 cents on the state of the current evidence base. So there have certainly been some meta-analyses and systematic reviews in this domain of digital therapeutic, the evidence for digital therapeutics in mental health care. I think from my standpoint, the challenge that we have in front of us is that the evidence base is largely very abstracted, and it's very difficult to get anything more than equivocal results with modest effect sizes here. So overall, I would say that the evidence base is sort of in its infancy, with a very limited precision in defining and evaluating the specific features of a digital therapeutic. And I think we really need a much more granular understanding of what a specific digital therapeutic provides in order to be able to assess it effectively for a given patient population. And at present, one aspect of this review paper that I'm citing notes is that we really don't have an adequate evidence base today to say that app-based therapeutics as a broad category are effective as standalone treatment. So again, going back to the contextualization of the solution, how does this tool fit into a broader architecture of the care that we provide and the solutions that we want to deliver? I really think that the challenge here is that we're not looking at digital therapeutics as things where there's a specific mechanism of action, right? We need to go probably several orders of magnitude more specific to understand what are the particular features of this given application that are particularly relevant to this patient population. And that's a degree of specificity that I just have not seen in the literature to date. And in my opinion, it's almost analogous, I think, to like a pharmacology study that just simply says, we treated the patient with mood stabilizers, generally speaking, and they got better, they didn't get better. Well, that doesn't help us a whole lot as psychopharmacologists if we want to know what was the mood stabilizer, what was the dose, what was the frequency of delivery, what was the mechanism of delivery, and all of those questions about potential mechanism of action of the specific pharmacologic agent for a particular patient population. So I think something roughly analogous exists in the digital therapeutic literature today, that it's overly abstracted. And I think in some way or another, to be effective and build upon each other's work in this community of innovators, I think we need a much more granular understanding of what a given digital intervention is doing. Now, to make that a little bit more concrete, I hope maybe this illustration of a specific use case might help us think through some of the challenges and the level of granularity that might be helpful in understanding the nature of the evidence base today and the opportunity that we have in front of us. So I'm taking a look at this systematic review and meta-analysis of app-based interventions for moderate to severe depression. And this was a study that looked at the use of CBT, ACT, and behavioral activation as the core component of these digital apps, and applied to various patient populations with moderate to severe depression. There's a total of, I think, 12 studies that were included, 13 studies that were included, and they included 3 from the US, 3 from Europe, 1 from Australia, and 6 from Asia. Now, taken in the most general results and discussion, the key takeaways that the authors described was that there was significant improvement with moderate effect size, and there was no difference in effect size from patients with a formal diagnosis versus self-report. Now, if you look at these key takeaways, the first thing that I would be wondering about if I was listening to this talk is, does that negate absolutely everything that this guy was just saying for the past 40 minutes about specificity of problem identification and solution formulation? And I don't think it does. It may seem that way on the surface, but I hope to go a level deeper to explain why I think the results are a little bit more nuanced. And in fact, the results do speak, in my opinion, to the need for very precise problem identification to formulate the right solution or treatment intervention. So the way that I think it may be useful to dig deeper in this study is to look at some possibly counterintuitive findings that were also revealed in this meta-analysis. The first was that the effect size was greater without professional support than for patients who had professional clinical engagement in their care. The second was that a brief intervention of less than 8 weeks had a larger effect size than a longer intervention, right? So sort of an inversion when we think about our known dimensions of causality. There's a dose-dependent relationship, right? But here we're dealing with sort of an inverse dose dependence, which is sort of strange. And then in addition to that, when they did a sub-analysis, it looked like the non-Western studies had a significant effect, and Western populations did not. Again, sort of possibly counterintuitive and confusing. So how do I make sense of this? How can we collectively make sense of these perplexing findings in the study? And here are the possible implications that I'd point our attention to. First, I think the differences in the subpopulation effect size may have a cultural component to efficacy, right? So when we look at Western populations and Eastern populations, as you all know, in the field of mental health care and dealing with mental illness, there's the issue of stigma. I might go so far as to say that I think it's not terribly controversial to say that in the Western world, I think we have done a little bit more work to effectively manage the stigma than in many East Asian countries and South Asian countries. And so it may be the case that stigma is playing more of a role in how patients get care and the type of care that patients seek out. The variables that correlated in this review and meta-analysis, the variables that correlated with effectiveness were that the patients tended to have socially limited engagement, right? So shorter duration without professional support. And as I was just talking about, in settings where psychiatric stigma may be greater, and that is in, we're presuming non-Western cultures. So now looking at the specificity of the problem, I would argue that perhaps what this study shows us is that app-only interventions may be most beneficial for patients and populations where stigma is a salient concern, and perhaps for marginalized populations with poor access to timely psychiatric care. So in patients who are readily willing and able to engage with professional clinical care, the effectiveness of an app-only intervention seems to wash out. But for other patients where accessibility and willingness to engage with care is much more limited, it seems that the effect size is significantly greater. Now, this study, I think, also shows us where we are today, but also points in the direction of where we could go to gain a more specific understanding of, again, sort of the mechanism of action by which app-based interventions are helpful to patients. To carry this work several steps further, I would be very interested to look more specifically at the user experience features or the user design features, using that framework of the 6 elements that we just previously reviewed. Can we look at those and quantify those dimensions effectively in our studies? And can we measure different apps against those different dimensions? I think that would be a very valuable thing for the field to do and carry us further in understanding the mechanism of action. In addition to that, I'm also particularly interested to delve deeper with understanding the patients themselves and who responds best to digital interventions like the app-based therapeutics that were used in this study. So what are the character traits? And can we consider these to be a function of the outcomes? Can we look at individual sense of self-efficacy and agency? Can we look at their reflective capacity, a sense of interiority, conscientiousness, looking at different personality dimensions, right? I think all of these would be very interesting and very useful to understand how we match specific solution to the specific patient. And then finally, further parsing differences in the modality of treatment and the potential relationship with symptom domains, right? If we think about the syndrome of depression, we're all familiar with the PHQ-9 And we know that there are different dimensions to the depression symptoms that patients may have and different presentations. Do the digital tools and the apps that we're talking about demonstrate more efficacy along certain symptom clusters or symptom domains than others? We don't know the answer to that yet, but I think it's a ripe opportunity for further study. So I hope with this example and delving a little bit deeper into this, you may see, as I do, that there's more opportunity for granular detail. And I think that's a pretty ubiquitous, I hope it's evident that that's a ubiquitous pattern of the need for more granular level understanding across digital health in the research that we do and the implementation work that we do as well. From there, I just wanted to also point your attention to the APA's App Advisor initiative. This was spearheaded by a research colleague of mine and collaborator, a very, very, very intelligent person, John Toros. He's a psychiatrist at Beth Israel Deaconess in Boston, and really one of the leaders in the field of digital therapeutics. And he, as I said, spearheaded this initiative. The App Advisor gives a framework for individuals, clinicians, to review potential new apps, new tools that come onto the marketplace. And when a clinician has a question of, is this potentially useful for my patient, this framework that's defined here in these different bubbles. And the only thing that I just want to sort of add an asterisk of clarification, the therapeutic goal, I'm not sure why they labeled it as such. What they really mean by that, if you go onto the website, is the element of data integration, but it doesn't really translate well. I just wanted to point that out. But these different domains, I think, are very relevant, and we can use the App Advisor as a reference tool when we're looking at new clinical tools, new patient-facing tools in particular. And I think there's also somewhat of a crowdsourced review of different apps. It's not exhaustive by any means, and it may, last time I checked, it looked slightly out of date, quite frankly, but there's some very pertinent information there that I think is worth looking at very least. But from there, I don't know, we have about 10 minutes left. I was thinking that we could either open it up for questions or very quickly, I had another section that I was going to get to, sort of depending on how much time we had. But maybe very quickly, in a couple minutes, I might just note that when we think about the problem of population health, I think one of the core things that we also want to look at is incentive alignment. I think that this is also an underappreciated concept. You know, where do we actually have an incentive to save money for patients and keep them healthy? And in my opinion, that really tends to be with employer-based healthcare insurance and Medicare Advantage. These are the two components of insurance where there's a financial incentive to the provider, to the payer, to keep people healthy. And as you might imagine, a lot of digital health companies are pivoting to engage more directly in a what we call B2B or business to business model, where they provide a population health service to employers to directly take care of patient employee mental health needs. And the reason for this is, going back to our model for population health of this schematic, is that the different portions of the population need different solutions to keep them healthy. So if we look at an average workplace, about 75 out of 100 of those employees will only really need support to maintain general well-being and wellness. And so there are more generalized wellness tools that would be useful to this patient population that would be different from the more precise, more clinically engaged digital therapeutics that we've in part been talking about. And then it's only really a very small proportion of patients that really need acute care. And that might be coupled with some digital tools to help enhance the care navigation pathway. All in all, this, I think, leads us to the question of how we look at a population of patients and try to put the right resources to the right patient at the right time. This is a very challenging problem to address. And there was an article in the New England Journal about this concept, which has been referred to as hotspotting. And it was also written about in the New Yorker several years ago, I think by Atul Gawande. And the idea is if you can allocate resources to a very small portion of the population who have an enormous impact on the overall cost to the healthcare system, and if you can keep those patients better more proactively, you can potentially do dramatic things to lower the cost of care in the United States, which as we all know, are dramatic, rising and accelerating at a extraordinary rate. The challenges that were discovered by this group that published their work in the New England Journal was that it's very difficult to figure out who to provide those resources to. And the reason that they articulated was that with the phenomenon of hotspotting, there's actually, so they use the iceberg metaphor. There's a certain small proportion of patients who are high cost, but there's a very, very large portion of populations who are rising cost. And in any given year, if you look at the snapshot, it doesn't give really a full picture. And the high cost patients and the rising cost patients are in a dynamic equilibrium where from that large pool of rising cost patients, it's very difficult, and the authors of this study articulated that for them, it was impossible to figure out who amongst that rising cost population was actually going to get above the water, so to speak, into that high cost domain. And so that's the work of data science in front of us. Perhaps AI tools may be helpful in continuing to investigate this problem and figuring out whether we can build better models to understand those rising cost patients. But it remains a perplexing problem that we haven't yet solved. So there's a lot of uncertainty from a population health standpoint, but a lot of opportunity at the same time to leverage specific tools for specific subcomponents of the problem. But with that, maybe I'll pause there or finish my part of the conversation. Hope that we might turn it over for some further discussion as a group and talk about what might be interesting to you and what might be particularly pertinent to the problems that you're trying to solve in your own work. I appreciate everyone's time and engagement in the talk today.
Thank you, Dr. Breitinger. We do have a question in the chat. We also had someone ask if you could go back 3 slides. And we also want to remind everyone that this presentation will be available on our website. The question is there any concern with addressing mental health needs of population via technology resources, such as smartphone applications, which may not be accessible by those in lower socioeconomic classes? This is especially relevant in some of the rural regions of Arkansas, which even with sufficient household income, reception and data connectivity can be unreliable.
Yeah, absolutely. It's a great question. One of the challenges that we have to think about from an ethical standpoint is when we invest in novel forms of innovation, who are we providing it to and who are we potentially leaving behind? And it's no simple question to answer, but it's spot on in the absolute importance of understanding that problem, that conundrum, and doing what we can to also engage with health equity. And I think I would suggest that maybe this is most effectively dealt with from a policy standpoint. And I think that if we are providing digital tools to support patients who might be more natively capable for navigating digital tools and might have the hardware devices to do that in comparison to some patients who might be impoverished, who might not have the cognitive abilities to navigate digital tools or might not have the financial resources for an iPhone or an iPad or something that provides a digital interface to communicate with care providers. That is a real legitimate challenge to the healthcare system. And I think as a starting point, the differences need to be measured, again, from a public health standpoint. And I think at a local, state, and federal level, adequate resources need to be provided to those specialized patient populations to not exclude them from care and not limit their access to care as we move forward on the innovation front. But it really requires robust, proactive awareness of this problem from a policy standpoint, in my opinion, as well as, from a systems implementation standpoint locally. I don't mean to bypass the importance of local engagement, but the resources need to be there to accommodate patients with specialized needs. I would sort of make the analogy of the Americans with Disabilities Act, recognizing that we as a society decided that in the name of equity, that we will make certain accommodations legal standards for a relatively small proportion of the population, so that we have access in public buildings and commercial buildings that's near universal. And that's a cost to society, but it's one that we decided is ethically necessary to forming and maintaining the type of society that we want and believe in. And that's how I begin to look at that problem. And I think we also begin to address it effectively by engaging with research in this area and studying it and providing the evidence base to say that this is a problem for this type of patient population, whether maybe that's the elderly, maybe that's the impoverished, maybe that's the cognitively disabled, and maybe there are many other types of patient subpopulations that I have not thought of that also are really important to consider in this equation. But I don't think underestimate the value of that problem and the importance of addressing it. And sorry, 3 slides prior, is this the correct slide that we were looking for, or was it a different one?
It's a different one. Go back, continue moving back. Going. Yes, that one right there. Right there. That's the one. Thank you so much.
Sure.
Thank you. All right. We know we are at the top of the hour. This was fascinating. I learned so much about this digital space, about what's currently happening and things to come. And we're hearing more and more about digital health, the digital health space, AI, how AI is going to be affecting healthcare. And so this has really been helpful. I have to admit, I don't have a lot of experience in this, but I have been seeing it more and more, in the literature. It's more pronounced. It's out there. And so I think that it's important for us to be aware of. This was a great opportunity, and I learned so much from you. Thank you. And I also love that you are starting to talk about and introducing us and encouraging us to think about what could this look like in the COCM model, because I think that that's going to be absolutely essential. All right, we know it is 9 o'clock. I want to remind everyone that we do have a link in the chat for your CEUs today. So please use that link. We appreciate you being here, and we will have this up. Jenny said we'll have it up next week. We will have it up. And Dr. Breitinger, we really appreciate you. This was absolutely phenomenal. Thanks, everyone, and have a wonderful day.
So much for hosting me. If anybody would like to reach out, happy to carry on any discussions. As Dr. Gibson and I were talking about before the talk started, I have a strong interest in thinking about collaborative care model, COCM, and how we continue to innovate in that domain. From a research standpoint, there's some things that I'm working on with my colleagues in developing digital infrastructure for COCM, but would be delighted to continue the conversation with anybody interested in the future. Feel free to reach out. I'm happy to provide my email and contact information. Perhaps through email, there's a listserv that I might be able to.
Absolutely.
All right. Well, thank you again. Very grateful for having me today.
Thank you. Oh, another quick announcement. I just want to make sure, speaking of COCM, Medicaid does have a COCM project here in Arkansas. And ABIN is supporting that project. We will be having office hours that are free and open to anyone in Arkansas who is interested in the COCM model. That will be next Friday, July 19th from 12 to 1 p.m. And we will have that up we will actually put the link on the ABIN COCM webpage. And please join us and we can continue the conversation and potentially reach out later to you, Dr. Breitinger, to get more guidance and to carry on this conversation.
Look forward to it. Thanks again, Kim. I really appreciate it.
Thank you. Have a great day.